Thanks for joining me for part 2 of this talk on the oral patient presentation. Here we will give you 2 examples of presentations for the same patient. We'll start off with a suboptimal presentation and finish with a better one. You can also find written, annotated copies of both examples in the description, which you might find helpful as a guide. Okay, so let's start off with an example of a suboptimal presentation, and then we'll move on to a better one. As well, you can find in the description links to annotated written copies of both examples, and I think it'd actually be helpful to follow along. So, Mr. P is a 64-year-old man with cirrhosis secondary to alcohol abuse with a previous history of admissions for ascites, who presents with 5 days of progressive shortness of breath. He has a past medical history of rheumatoid arthritis, which was diagnosed 10 years ago. He also has diabetes type 2, which is well controlled on metformin with an A1C of 7 last month. He's got hypertension, well controlled on ramipril. He had a TIA secondary to a small vessel occlusion 5 years ago. He had a left total knee replacement in 2004 and bilateral cataract surgery in 2012. So the HPI, Mr. P was diagnosed with cirrhosis 3 years ago when he first presented with ascites. Since Mr. P previously struggled with alcohol abuse, and since his workup for other causes of cirrhosis were negative, it's felt that his cirrhosis is secondary to alcohol abuse. He was discharged from that admission on diuretics, 100 Spiro, 40 Lasix. However, in March, he presented hospital once again with ascites and underwent a therapeutic paracentesis. He was then discharged with a doubled diuretic dose of 200 Spiro and 80 Lasix. Then, about 5 days ago, Mr. P began experiencing shortness of breath. It was a gradual onset, and it started with exercise. Normally, he can walk 15 blocks before becoming short of breath, but now he's short of breath at rest. 5 days ago, this shortness of breath resolved with rest, but it's gotten worse, and now he's short of breath at rest. He's also complained of cough beginning 5 days ago. He occasionally coughs up whitish sputum, but there's no hemoptysis. He's also complained of abdominal discomfort for the past 2 weeks. It was gradual onset throughout his abdomen. It's a dull, bloated feeling, non-radiating, 3 to 5 out of 10 in pain, and constant. There were no alleviating or aggravating factors. He denied any fever, chills, night sweats, weight loss, rigors, fatigue, vision or hearing change, headache, confusion, rhinorrhea, sore throat, tinnitus, neck stiffness, chest pain, orthopnea, platypnea, PND, edema, lightheadedness, loss of consciousness, nausea, vomiting, diarrhea, hematemesis, hematochezia, melena, early satiety, constipation, obstipation, joint pain, or rash. Medications, he takes ASA 81 milligrams daily, atorvastatin 80 milligrams, metformin 500 milligrams BID, spironolactone 200 milligrams, Lasix 80 milligrams, methotrexate 25 milligrams PO weekly, ramipril 2.5 milligrams. He takes an aspirin every time he gets a headache, and about twice a month on average, and he takes a daily vitamin C supplement. He has no known drug allergies. Mr. P struggled with alcohol abuse for many years in the past, but fortunately he hasn't had a drink for about 3 years now. He doesn't do any IV or recreational drugs, and he's never smoked cigarettes. His family history is positive for ovarian cancer in his grandma, diabetes in his father, osteoarthritis in his mother, and his cousin is gluten-free, but he's not really sure whether this is actually celiac disease. Just a fad. The patient said that for the past several years, he's been waking up about twice a night to go pee, and sometimes he has some hesitancy, but it's been stable and it's not bothering him that much. On physical exam, the patient appeared well. His vitals were stable except for a rest rate of 24. In his hands, there was some clubbing. There were no nicotine stains, Janeway lesions, Osler nodes, splinter hemorrhages, pulmonary erythema, and cap refill was less than 2 seconds. Head and neck, he had normal fundoscopy. The tympanic membranes were normal. His throat was normal. His neck was supple. I may have palpated a cervical node, but I've never actually felt one before, so I'm not entirely sure. But if anything, it was small, maybe about 2.5 millimeters. He had a normal thyroid. The patient was also using accessory muscles to breathe. There was dullness to percussion and decreased tactile firmness at the right posterior base. I thought I heard decreased breath sounds in the right base and maybe a friction rub, but I've got a really old stethoscope and my hearing's not that great, so I can't really be sure. The JVP was 2 centimeters above the sternal angle, biphasic, non-palpable, changed with position and inspiration, and AJR was negative. There were no carotid bruits. There was normal upstroke and amplitude. There was no radial brachial delay. There were no palpable thrills or heaves. The PMI was non-displaced, non-enlarged, non-sustained. Again, I think I heard a 1 out of 6 diastolic murmur at the right second intercostal space, radiating to the axilla. But again, not entirely sure. Old stethoscope, bad ears. The abdomen was distended with bulging flanks. It was non-tender. There was no rebound tenderness. Negative McBurney's, Rovsing's, Murphy's, Gray Turner's, Cullen's, SOAS, and operator signs. There was a fluid wave and shifting dullness, and DRU is normal. I did a screening neuro exam as well. Cranial nerves 2 to 12 are intact, normal motor and sensory screen, and normal coordination. CBC, hemoglobin 135, white blood cell count 10, platelets 100,000, sodium 134, potassium 4, creatinine 100, glucose 9, liver enzymes were elevated in a mixed picture pattern, normal troponin, the ECG was normal sinus rhythm, chest x-ray showed a moderate right-sided pleural effusion, and a bedside abdominal ultrasound showed a large amount of free fluid. So, in summary, this is a 64-year-old man who presents with 5 days of shortness of breath, cough, and abdominal pain, with a past medical history of cirrhosis, rheumatoid arthritis, TIA, hypertension, and diabetes. His physical exam was significant for a rest rate of 24, O2 sats of 91% on 4 liters, clubbing, dullness to percussion, and decreased breath sounds in the right lower lobe, abdominal distension, fluid wave, and shifting dullness. Platelets and albumin were low and liver enzymes were elevated. Chest x-ray demonstrates pleural effusion and an abdo ultrasound showed ascites. So my problem list, first issue, cirrhosis. Again, I think this is secondary to alcohol. His MELD score is 33 and he's child PU class C. The differential includes Wilson's disease, primary biliary cirrhosis, autoimmune hepatitis, hepatitis B and C, and NASH. But again, tests for these were negative 3 years ago. I think we should call GI and ask them to see if there's any role for maybe a TIPS procedure and just a follow-up on his transplant status. And I think he needs another abdo ultrasound to screen for HCC since his last was 9 months ago. Second issue is ascites. So I think this is due to portal hypertension from cirrhosis. This could also be malignancy, heart failure, or SVP. He needs a therapeutic paracentesis. We can send the fluid off, calculate a seg, and I would consider holding diuretics at this point and gradually restarting them after the fluid drainage while closely monitoring his creatinine. And again, we'll call GI and ask about the role of a TIPS. Next issue is the shortness of breath. So I think this is due to his pleural effusion. It could also be another respiratory issue like pneumonia, pneumothorax, pulmonary fibrosis, but I think this is less likely. It could also be cardiac, secondary to like heart failure or ACS, but again, less likely. I don't think he needs antibiotics right now, but I guess we could send off some cultures. And we'll monitor his rest status closely and do frequent vitals for a bit. Next issue, pleural effusion. I think this is from hepatic hydrothorax, but it could also be from malignancy, CHF, or rheumatoid arthritis. I think we should do a therapeutic thoracentesis as well, draining up to 2 liters of fluid. We'll send it off. We'll do a Lights criteria. In the meantime, we'll salt restrict him to less than 2 grams a day and fluid restrict him to less than 1.5 liters a day. Next issue is low platelets, prolonged INR. I think this is from cirrhosis. It's stable. We can monitor. Regarding his elevated liver enzymes, again, it's a mixed picture consistent with cirrhosis. We'll just follow it. Same with his rheumatoid arthritis. Keep him on his methotrexate. Follow. Next issue, hypertension. Stable. I think we can continue his ramipril for now. As mentioned, we'll keep a close eye on his creatinine and we'll hold it if necessary. Diabetes, again, continue the metformin, follow his sugars, considering holding the metformin if his creatinine bumps. Finally, some housekeeping. He's on deltaparin DVT prophylaxis, and he is full code. Okay, so now hopefully a better presentation example. All right, I saw Mr. P. This is a 64-year-old man with decompensated alcoholic cirrhosis and rheumatoid arthritis who presents with a 5-day history of progressive shortness of breath. So Mr. P was in his usual state of health until 5 days ago when he began experiencing new, gradual onset, worsening shortness of breath. Normally, he goes for a 15-block walk every single day without becoming short of breath at all. But 5 days ago, he started becoming short of breath after walking only about 2 blocks, which is highly abnormal for him. At that time, 5 days ago, the shortness of breath resolved at rest. However, over the course of the next several days, his shortness of breath has worsened. And actually, as of this morning, he's been having shortness of breath at rest, which is what prompted him to come to hospital with his wife. Associated with the shortness of breath was a non-productive cough, but there was no chest pain, orthopnea, platypnea, no PND, edema, or syncope. In addition to this, he also complained of this worsening abdominal discomfort for the past 2 weeks or so. He denies any frank abdominal pain, but he says that he's been feeling increasingly bloated and that this is quite similar to his previous episodes of ascites, which required drainage. He denied any nausea, vomiting, diarrhea. He hasn't had any melena or hematochezia or early satiety. So regarding his cirrhosis, he was first diagnosed 3 years ago when he first presented to hospital with ascites. At that time, he responded quite well to diuretics. He was discharged home. He was actually managing well on a home regimen of 100 Spiro and 40 Lasix for quite a while. However, 4 months ago, he was admitted to hospital again for worsening ascites, which then at that time required a therapeutic paracentesis. And then he was discharged eventually with a doubled dose of Spiro and Lasix. In the community, he's followed by a gastroenterologist, Dr. G. His last visit was approximately 3 months ago, during which he was put on the wait list for a liver transplant. His last liver ultrasound was 9 months ago. It was negative for any masses. And currently his MELD score is 19 and his Child-Pugh class is C. And aside from the ascites, he's had no other complications of cirrhosis. Now, aside from all of this, there were no other symptoms. So he denied any fever, chills, sweats, or weight loss. He didn't have any calf tenderness. There was no joint pain or rash. And as well, he doesn't have any history of cardiovascular disease. He has no risk factors for DVT, such as recent immobility or surgery, or history of malignancy or of a DVT or PE. His other medical issues include rheumatoid arthritis, which was diagnosed 10 years ago and well controlled on methotrexate. He's got type 2 diabetes, which is well controlled on metformin with an A1C of 7 last month. He has hypertension, which is well controlled on ramipril. And he had a TIA, which is thought to be secondary to small vessel occlusion about 5 years ago. So he takes spironolactone 200 daily and Lasix 80 milligrams daily for his ascites. He's on methotrexate 25 milligrams PO weekly for his rheumatoid arthritis. He's on ramipril 2.5 milligrams daily for hypertension. He takes ASA 81 milligrams daily and atorvastatin 80 milligrams daily for secondary stroke prevention after his TIA. And he's on metformin 500 milligrams BID for his diabetes. He has no known drug allergies. Social history. So Mr. P lives at home with his wife here in Vancouver. He's usually fully independent. He has one son who is a GP in Vancouver, whom he would like to be involved in all the decision making regarding his care, and who would actually serve as his substitute decision maker should the need arise. Mr. P is a retired financial advisor. He did struggle with alcohol abuse in the past, but he has not consumed any alcohol for the past 3 years since being diagnosed with cirrhosis, and he's never smoked and does not use recreational or IV drugs. His family history is non-contributory. His review of systems is also non-contributory. So on physical exam, upon entering the room, the patient was sitting up in bed. He was breathing quite quickly and audibly. He's obese and jaundiced. His vital signs are as follows. Heart rate is 92 and regular. Blood pressure is 130/75. Respiratory rate is 24. O2 sat is 91% on 4 liters nasal prongs, and his temperature is 37.2. His extremities were warm. There was some clubbing present. His cap refill was brisk. His neck was supple. There was no lymphadenopathy, and he had a normal thyroid. His resp exam, so he was using accessory muscles to breathe. There was dullness to percussion and decreased tactile fremitus at the right posterior base. And there were decreased breath sounds and also a friction rub also in the right posterior base. And the remainder of the lung fields were clear. The JVP was 2 centimeters above the sternal angle. He had normal S1, S2 with no gallops or murmurs. There was no edema. His abdomen was distended with bulging flanks. There was a positive fluid wave and shifting dullness. His abdomen was non-tender. There was no rebound tenderness. There was no hepatosplenomegaly. And there were no other signs of chronic liver disease such as asterixis, pulmonary erythema, spider-angioma, caput medusa, and his DRE was unremarkable. The labs were as follows. So he had low platelets at 100. He had a low albumin of 30. His INR was elevated at 2.2. He had a high bili at 35. And then he had a mild mixed pattern liver enzyme elevation, which was stable compared to 3 months ago. His hemoglobin was normal. His white count was normal. His creatinine was also normal at 100. Serial troponins done in the emerge were also normal. His ECG showed normal sinus rhythm. His chest x-ray showed a new moderate-sized right-sided pleural effusion, but no evidence of consolidation, pulmonary edema, or cardiomegaly. And a bedside abdominal ultrasound showed a large volume of free intra-abdominal fluid. In summary, this is a 64-year-old man with decompensated alcoholic cirrhosis, complicated by refractory ascites, who presents with acute worsening shortness of breath and abdominal distension, and was shown to have a moderate volume right-sided pleural effusion on chest x-ray and a large volume of ascites on bedside ultrasound. My working diagnosis at this point is hepatic hydrothorax and ascites secondary to portal hypertension, given his history of end-stage liver disease and his recent worsening ascites. The differential diagnosis for shortness of breath and pleural effusion includes number 1, malignancy, although I think this is less likely given the time course, the lack of constitutional symptoms. He had a recent normal liver ultrasound, and he doesn't have any history of malignancy. This could also be a parapneumonic effusion, but I think this is unlikely. He doesn't have any infectious symptoms. He had no consolidation on his chest x-ray. This could also be congestive heart failure. But again, I think this is unlikely in the absence of symptoms that are specific for heart failure. He doesn't have any history of cardiac disease. He doesn't have any pulmonary edema on his chest x-ray, so I think it's less likely. This could also be a rheumatoid effusion, either directly due to his rheumatoid arthritis or as an effect from his methotrexate. But he's been on methotrexate for quite a while. His rheumatoid arthritis has been stable. He hasn't had any recent flares, so this is lower on my differential. And the differential diagnosis for his ascites also includes malignancy. It also includes spontaneous bacterial peritonitis, but I think this is unlikely given the absence of any abdominal pain or tenderness. And again, this could also be due to congestive heart failure. So my plan, first issue for him is his shortness of breath and pleural effusion. I think we should do a therapeutic thoracentesis and drain 2 liters of fluid. We can send the fluid for protein, LDH, cell count, culture, cytology, etc., and calculate his Leitch criteria. And we'll also arrange for a paracentesis to be done at the same time as the thoracentesis for convenience. And as well, we'll salt restrict him to less than 2 grams a day. We'll fluid restrict him to less than 1.5 liters a day. I want to monitor him closely for any further respiratory decompensation. Currently, he's stable on 4 liters, but I've ordered Q2 vitals in the meantime. And we'll do BID creatinines just to keep a close eye for hepatorenal syndrome. Second issue is his ascites. So as mentioned, we're going to arrange for a therapeutic paracentesis, and we'll send that fluid off so we can calculate a seg. I would consider holding his diuretics right now, and then we can gradually restart them after we've drained off all that fluid while closely monitoring his creatinine. As well, I think we should call GI and specifically ask them about consideration for a TIPS procedure and just to check on the status of his transplant. His third issue is his cirrhosis. So again, we're going to call GI. I think he also needs an abdominal ultrasound to screen for HCC since his last was 9 months ago, and he should have one every 6 months. His next issue is low platelets and a prolonged INR. I think this is most likely secondary to a cirrhosis. It's stable from previous. I'm happy to just monitor this for now. Next issue is elevated liver enzymes. Again, it's a mixed picture, kind of consistent with his cirrhosis, stable from previous. We'll just keep an eye on it. Next issue is his rheumatoid arthritis. He's very stable on methotrexate. We'll continue for now and monitor. Next, his hypertension. He's stable. We'll continue his ramipril. We're going to be monitoring his creatinine, so we'll hold his ramipril if there's any evidence of an AKI. And then his diabetes. So again, we're going to continue his metformin, and we'll hold if there's any evidence of an AKI. And finally, best practices. He should be on DVT prophylaxis with dalteparin, and he is a full code. Thank you. So that concludes this talk on how to give an oral patient presentation. Again, as a reminder, you can find written annotated copies of both of these examples, as well as a written guide to the oral presentation in the description. And I hope that you found this helpful, and I wish you all the best on your rotations.